Good afternoon, everyone. My name is Garrett Schmidt, and I am Managing Editor for ACO Exhibit Hall, and would like to welcome you all to today's webinar entitled Connecting to and Sharing Data, What's New in ACO Interoperability, hosted by Health Endeavors. A few items of note before we get started. First of all attendees have joined today in listen-only mode, so you don't have to worry about muting your mic. We can't hear you. Second thing is I would like to let everyone know that this webinar is being recorded, so you will have the opportunity to watch the session again or share it with colleagues. And a link to the recording will be emailed to all of the attendees following the presentation. But it may be tomorrow when we send that out. And finally, during the webinar today, you will be able to submit questions to our presenter using the question icon at the top center of your screen. And we will answer as many of those as possible in the Q&A session at the end. These questions are also being recorded, so even if we're unable to get to yours during the allotted time today, we will follow up to answer that via email afterwards. All right, in today's webinar, our presenter will discuss the importance of interoperability to ACO performance. And this presentation will combine information from well-known industry research in addition to real-world examples and solutions. Our presenter today is Chris Gates, who's the Chief Executive Officer for Health Endeavors. So welcome, Chris. Take it away.
All right. Thank you for the introduction, and thank you for sponsoring this event today. I appreciate everyone joining. I know you have the Medicare webinar coming up right after this, but I appreciate everyone joining. What we're talking about today, as you said, was interoperability, and that interoperability is all about computer systems being able to exchange data, but more importantly, to make use of that information, to take action on that information. This here is just a laundry list of all the different types of data, and we'll be talking a little bit about each one today, from the provider EHR to how does the consumer contribute, to how payers are now contributing, especially Medicare, lab, pharmacy, and radiology. But we really want to see this data be in a format that's easily exchangeable, but more importantly, it's actionable. So let's talk a little bit about the standards that are in your EHR, and I promise not to bore everybody too much with going into the architecture of the EHR, but just to give a high-level overview of what is available today and what is coming, FHIR, but needs more time to develop. So your primary EHR data exchange standards are the CDA, which is the Clinical Document Architecture, which is basically the EHR record. The CDA is the EHR record. It comprises all the components of the medications, the patient history, all of those pieces. A subset of that has come out in the last few years is the QRDA, the Quality Reporting Document Architecture. Think of it as the QRDA as a template of the CDA. What they're trying to do is create a subset of the CDA, the QRDA, in order for you to pull your quality out. And there's two components of the QRDA. There's a 1 and a 3. The 1 is the one that we want to use as a vendor because it has the patient detail. A QRDA 3 just provides you with an aggregate, how did you perform on the BMI measure as a whole, whereas the patient detail gives us the detail to be able to score a patient, a provider, a facility. FHIR is new, it's quickly developing, however, it's primarily only available in major EHR systems. Cerner, Epic are the two leaders from what we see right now, and then the other FHIR resource that is the largest right now resource that's out there is the Medicare Blue Button, which is a FHIR EOB, a financial record is what they call it, but it's really the health history of everywhere that patient has been, similar to your ACO data. So we'll talk about each one of these a little bit. And again, I promise not to bore you with too many details about it before we get into how you might use this data. Okay. So the CDA is, as I said, I'm not going to read this line by line on the slide, but it's basically the electronic health record. It's basically comprised of, like I said, it has all the different components. When you look at an EHR, it'll have medication, it'll have the patient's demographics, and it has all these components that are intended to be structured so that that data is always collected in that format, the CDA, so that it can be easily exchanged. The problem with CDAs is every EHR, while they follow the protocols of what needs to be in one, they didn't always structure them exactly the same, not in the same order. Some of them let you add fields to the CDA, so you can get outside the standard CDA. That's why people say, well, the CDA is great, but there are variances in it. But it basically is the EHR record, and it is the electronic record that you would exchange. For example, if you were sending a direct message to another provider, this is the record that you would be sending over. And then we have what we call the CCDA, which is basically a consolidated CDA of 8 critical components of a complete CDA. So it's a consolidated summary of the health record, the electronic health record, plus it can include unstructured data. So you'll see people refer to both. The CDA is the broad overview of defining how that medical record, all the components of it. The CCDA consolidates it to the 8 most critical documents to make it a little bit smaller record that can be exchanged, and it will include unstructured data as well. FHIR, you'll hear people recall FHIR as a resource. They don't call them elements or like the CDA modules, really. It's all about resources. There's a different resource of data, and that resource is defined as to what it comprises it. So each resource in the FHIR has a definition, what the data types are, a common set of metadata, and then there's a human readable part as well. So we're just going to take a look at a little bit more of what the FHIR spec looked like. So a lot of people ask me, what's the difference between FHIR and CDA? Well, one thing everybody's hoping is that the FHIR stays as the resource that it's defined as, that it doesn't get manipulated or changed like the CDA has. It's become a little bit, there's variations of CDAs, as we all know out there. We're hoping that FHIR stays in the resource as it's defined, and that it's utilized as it's defined. But again, FHIR is really only the 2 big EHRs, Epic and Cerner, and Medicare is using the financial one. So it clearly defines all the set of modules. Probably easier to view it is to look at what they call the resource. So this might look a little small on your screen, but when you get the slide deck, if you click on that resource index, it's going to take you into every resource. So, and this is all available on Medicare's, their public sites for the FHIR, the HL7 site as well. You can click on those resources, and you can click on patient, for example. So if you click on the patient resource, it's going to tell you everything that's included in that resource. If you were to request that resource from a FHIR API call, for example, we'll talk about how that would work, you would get everything that's in that patient resource. If you requested the financial one, like the Medicare Explanation of Benefits resource, you're going to get everything that's in that resource. So it's all defined into resources. I would say, in my just looking at it as a layman person, the CDA is a really big document. It has lots of different components, whereas the FHIR, you're able to break this up into different resources easier. I only want the financial. I only want the patient demographics. I only want patient demographics and medication. So you're able to choose more selectively which resource you want. And there's a lot of different resources out there. But as you can see, they're all clearly defined. So if I drilled into the patient resource, you can see I can get demographics, age, gender, date of birth. I can also get their photo. There's a field for photo. So this defines, if I make a call for the patient resource, a FHIR call to the FHIR API of Epic, Cerner, I would say Allscripts is also on their way to, they have a FHIR sandbox as well. So all of them are on their way, but right now it's all in fast development. And maybe not all of the resources are available in each EHR. But you can see how you can more selectively choose what you want. So instead of I want the CDA, which could be a huge document, all I want is to call a patient resource and the medication, or patient resource and their financial, if I'm working in the financial area. So again, you pick and choose more what you want, which resource you want. It will break it down to faster retrieve exactly what you're looking for. So right now, the largest FHIR resource, besides the EHRs, which are coming along with you being able to do a FHIR call for the resource that you want, is Medicare Blue Button. Everybody's referring to it as the FHIR EOB, Explanation of Benefits. It is called the financial resource when you go to the resource page for all the resources you can request, and it is the largest accessible database today for FHIR. It's 55 million patients, beneficiaries are in this database for you to go and retrieve data. Yes, the beneficiary has to be the person that says you can get my data, but in an ACO, you're back to that today anyway. You're back to the person saying, yes, I agree to share my data, and if they call Medicare, they opt out, but you still have to notify them. The FHIR EOB resource, again, is more defined. It also is more updated more often, weekly rather than monthly. So you get 4 years of health history for a beneficiary when they share weekly updates, and it includes inpatient, outpatient, durable medical equipment, and pharmacy. But again, right now it is the largest FHIR resource for 55 million beneficiaries. So we talked about the two main pieces of data that are in the EHR. You've got the CDA and you've got the FHIR now, and then the CDA can be broken down into QRDA, which is your quality component. And we'll talk about how that quality component will greatly assist you this year, because all the measures you're doing in an ACO this year are in the QRDA. Past years they have not been, and you've got some that are in the QRDA that you can easily extract from the EHR, but you've got others you couldn't. Now this will be the first year all of them are in the QRDA that you can pull from your EHR. We'll move into that next. So again, we've got our types of data. Now, how are we going to exchange that data? Interoperability requires not only data, but it involves the exchange of that data, and then our last component is how do we use that data to make it more actionable. So we've got the application program interface, you often refer to it as APIs. The EHR specifies how the software components will interact. For example, they tell us, Allscripts has a sandbox we go to, and they tell us in their API how we can interact with them to retrieve FHIR data or make a GET call for a CDA, for example. But they're specifying, the EHR is telling us how we can exchange data and extract it, and what the fee is, if there is any, for us to pull data and push data. So an application program interfaces both ways. The other option is an encrypted string. API is the highest, the best option for exchanging data. An encrypted string is where, for example, we would send you the data sent in an encrypted string, and you, the end user, writes the code to display it. It creates a single sign-on experience, so if you wanted this data, for example, put into a self-insured employer plan portal and they had their own IT team, we could send them the encrypted string and they could set up the display, so anytime an employee logs into their employee portal, they're going to have a single sign-on experience to get to their claims history, for example. So an encrypted string really relies on work by your end-user tech team to do. Then there's direct message, which almost every EHR has a way to attach a CDA to a direct message. It's really just secure email, but it's just a CDA attached usually to the direct message and it's sent to another provider, or a summary record from the EHR that's sent to another provider. And then you've got text messaging, which we'll talk about as we move forward, which can really only be notifications, because the text message is not secure. If you put PHI in it, they still have to log into a secure portal, or it's not compliant with the HIPAA regulations. So let's talk first about the encrypted string. We'll just show you a quick graphic of it. So encrypted string means we sent the data to the end user in a data set. We've strung all that data together that you wanted from your ACO claims data or from the Blue Button data. We string it together, we send it to the end user. Maybe it's a self-insured employer, maybe it's an EHR, or another vendor. The end user then will code the data to render the display in the EHR or like an employer portal. So you see that's just a one-way, send the data, you render it, you're giving a single sign-on experience, but you're maybe in more control of the data and your IT is managing the process. Now, a patient match application program interface, which does mean we have to match the patient, can involve sending, receiving, retrieving, pulling, both, a push-pull. So in this example, a provider team with an API can open the patient record in the EHR, in an API. The patient match occurs. Once that patient is opened, you click on that patient in the EHR, the patient match goes out to search, is there any data in that vendor's database that matches this patient, yes or no? If there is, then the patient history, for example, from our tool will render in the EHR on that patient while that patient's in the office in front of you or while you're on that patient's record. So this is a true API. Again, you're in the EHR, you click on that patient, it searches a match for any of the vendors that are participating in your API, such as Allscripts. It will then render the display of data that that vendor, such as us, is pushing to you, such as the patient history. At the same time, a vendor can do a call as well. We can push and we can pull. So at the same time, we can do a pull of a CDA. We're working on doing a pull of a QRDA, your quality document, basically. It's your quality template underneath a CDA. So you can do a pull of that for quality reporting purposes. So an API has lots of options for interoperability. Again, it can pull and push data both. So again, the Medicare Blue Button is the largest today. We've touched on that. It will give all of the diagnoses, all of the medications. It'll give a full health history for 4 years for that consumer. So what is that doing in the industry? Medicare has now opened up for 55 million patients, the largest application program interface there is for healthcare data today in the United States. And so they can, as the top tier, start pushing that down to other vendors such as us, to EHRs, to create our own APIs for vendors to access the data, because Medicare is giving it to you in a raw format, same as the ACO files that we get. It's a pretty raw format. It's just the data rendered to you in a resource, a financial resource. So we need to take that data before we put it in the application program interface and make it more usable to the end user, and we'll show you different ways we've done that. But what this is really doing is opening up the API for all vendors that are approved by the consumer. So once a vendor says, yes, I'm going to sync down that Blue Button data with an approved vendor, I can then decide that vendor can be their own API, including an EHR can be their own API. Who does the patient want to share to from them? Should the urgent care and emergency department be able to access that API? If I come to the emergency department, this is the 55 million people in this database. Should I be able to put in the patient's information and retrieve their data if the patient has said yes? Same with insurance agents. Part D plans rely heavily on the consumer's information in order to generate the best plan for them. Part D plans are very complicated. You have the donut hole time, and it really depends on what drugs you're taking, who your pharmacy is, and who your providers are. So if I can share that with my insurance agent, I can get a better quote on a plan. And so they should be able to access the repository as long as the consumer says yes. Same with Medicare supplements, life insurance underwriting, hospital surgery pre-certification teams, and any other healthcare provider. So just start thinking of the data repository that Medicare has opened up in the last year. This has only been around for about a year. I think April of last year they went officially live. So now other vendors, including EHRs, can start creating their own API, and everyone can start accessing this data. Again, the beneficiary, yes, has to say yes, but then anyone can, that the consumer says, yes, I'm going to share with, you go ahead and share. So everybody's saying, when I first got in this business 20 years ago, just for the things we were doing 20 years ago, I was like, well, this is great, everything that's going to be coming out over the next 10 to 20 years. But what's wrong with the data? Then we start really getting into the data, and we start seeing a patient match may never be able to be made unless first name, last name, date of birth, gender, insurance number, and medical record number, some combination of those match. So one of the biggest problems right now in interoperability, and we call it the Clean Up the Data initiative, is we need to get our data cleaned up. The first name and last name need to be your legal first name and last name. We need to verify date of birth is correct, gender is correct, and we need to start getting those MBI, is not Hickens anymore, MBI numbers for Medicare, and for commercial patients, their insurance numbers. This is the most unique match. Otherwise, you're matching first name, last name, date of birth, and gender. And we'll show you some of the problems with that. So if Bob Jones is in my database as March 20, 1967, but really Bob Jones in his insurance and his legal name is Robert Jones, and his date of birth is March 20, 1968, we won't find a match on this patient. So the data analyst is trying to figure out, why can't I find Robert Jones? This is one of the biggest issues in interoperability. While the FHIR resources are great, and they will greatly improve the exchange of data because you'll be able to pick and choose what you want on that patient, if you could never find a match, you will never be able to pull the resource. So one of the biggest initiatives needs to be front desk staff checking in a patient. Anyone that's touching that patient's data needs to start looking at it and saying it needs to match exactly what your legal name is, first and last, date of birth needs to be correct, and I need your insurance information, or I'm not going to be able to find that patient and pull that FHIR resource. No matter how wonderful the resources are, we won't be able to find them. Same with quality data. This is actually, unfortunately, a real-life example. Enter BMI. You need to use those discrete fields that the FHIR and the CDAs have set up. If you don't use those discrete fields, they can't be pulled into that QRDA. So this is kind of a simplistic example, but if you are entering the weight in the BMI field, what's going to happen? A data analyst is going to say, oh, a BMI of 150, are you kidding me? So the data needs to go in the discrete fields. So two big initiatives we see to kill the interoperability we just talked about is clean up the data, the demographics, and use those discrete fields in your EHR or you won't be able to utilize the QRDA or the CDA for the purposes you want to. So again, front desk, start a program. Let's get the demographics right for every patient. Name, date of birth, address, gender, or FHIR is not going to be useful. CDA won't be, QRDA won't be, unless we're using those discrete fields and we can find a match on those patients. So we're talking to ACOs today primarily. Your goals, if we break them down into just two buckets, is to improve quality and health outcomes and lower costs. So let's see how we can start applying those goals that you have, right, to interoperability. So let's start with the quality metric, the group practice reporting option. So while we all may think Medicare is making the quality measures more and more difficult for us, they made a huge change this year. Every measure in your data set will be part of what we call an ECQM, which generates into the QRDA. So Medicare takes each one of those measures that you are completing and they build a structure for the EHR to follow, and they call it an ECQM, Electronic Clinical Quality Measure. So the EHRs are to build the quality measure to this spec in their EHR so that it can be exported into the QRDA, and the QRDA is what is the exchangeable data format for vendors such as us to take and to score all your patients and remit to the repository. So I'm not going to read all this to you again, but again, the ECQM is the format that is expressed by Medicare in order to come up with a common structure so all EHR vendors can say, we're going to code the BMI ECQM this way. And that's how it will be coded everywhere so that it can be generated into the QRDA. So think of the QRDA, again, as a CDA template. It only includes the quality measures information in it. And there's two categories. There's a category 1, which is the patient detail report, which is what we want, because we can manipulate that into scoring a provider, a patient, a facility, a division, a subgroup. That's how we can sift through that data, but because we need the patient identifiers. And then there's a category 3, which is basically, if you want to know your report today, pull that category 3 and it's going to tell you your results for a given population for a period of time. So your quality data for an ACO should be our EHR ECQM. Let's talk to our vendor about the ECQM measures that are in the system and extracting a QRDA. So the quality metric data is collected in the EHR as an ECQM. It's transmitted. The EHR transmits that data to your data center repository as a QRDA1 for remittance to the Medicare, who now has an application program interface. In years past, for every ACO, 50-some plus ACOs, we had to do a manual upload for 50 ACOs every single day. I think one year we had 60-some. Every single day we had to upload. Now Medicare has created their own API where we just click one button and all files go to Medicare. So it's getting more and more seamless, more and more interoperability. So we start with the ECQM, generate it into a QRDA. It goes up to the API every single day during your reporting period. And then the QRDA can be transposed by a vendor such as us into a scorecard. You'll see over to a right example scorecard many of you have seen. So again, we're getting more standardized as far as the process of quality. So your data center repository should be focused on collection, gap analysis, performance scoring, and then reporting to the Medicare API. And I just want to take this chance, when we get to that slide, to remind everybody, make sure you run your optimal gaps, and we'll talk about what those are. So again, your process now with the QRDA, and we're urging everyone, get on your EHR vendor, get that QRDA to us. We have a mechanized way to process that within 1 to 2 days, or less for some of you, where it will automatically go into our system. Every measure should be in that format. The ECQM format, there should be a measure that's extractable to the QRDA1 so that you can get your gap analysis, all your completes and incompletes on a more consistent basis. So set up your QRDAs to run weekly, monthly, quarterly, however often you want to probably do your scorecards and get if you're going to do patient outreach for their gaps. It'll also generate, QRDA will generate your performance score so that it goes seamlessly into a vendor system to create your gap analysis that I just showed you, completes, incompletes, skipped, etc. Then it will score everyone once the gap analysis is complete. And then I just want to remind everyone, as we're in the GPRO season, be thinking about your optimal gaps. You want to submit the best data set you possibly can of that QRDA. You only have to submit your random sample, but let's submit the best of that random sample. QRDA comes in, we process it, we tell you your gaps, we tell you your score, and then we're going to tell you what is the best submission. 1 to 248, 1 to 300 in a module, 1 to 616. What's the best submission for you as an ACO? What if your EHR can't generate a QRDA? You should be changing systems. Most all certified EHRs have them today, and they are it's usually around March or April where they finally get the new specs for 2019, for example, implemented, but most of them are fully on their way to QRDAs. If not, get a timeline from them for implementation, but this is how Medicare foresees quality being exchanged, is they will be all ECQM measures in the future. So what about non-ECQM measures, which there's a lot of? Well, you don't have any more today. Some of the EHRs may take a little time to get all of them into the QRDA, but medication reconciliation, for example, post-discharge is gone. It's not a measure in 2019, and it's not an ECQM, so it's gone. If you're not an ACO and you're going to be moving to do MIPS, then don't choose the non-ECQM measures. Choose only those that are in the QRDA for extraction to make it easier and less expensive for you to have a standardized extraction of the measures that are ECQM, the 2019 ACO GPRO measures, for example. This is just a slide so you can go out to the measures, explore them, and you can go to all the ECQM measures. So quality should be tremendously easier for ACOs. Medicare took the feedback from everyone and said, we agree. ECQM, QRDA, do the extract, get it to your data center for processing, and get it to us in the API, which we have automated. So they have come a long ways in interoperability with the quality measures. But you've got to be doing those ECQM measures. And even if you went to MIPS, why change measures if you leave the ACO program? Because your providers already know all those measures. So stick with the ECQM measures that can easily be pulled into the QRDA. Promoting interoperability used to be meaningful use for a year, advancing care information. It's now called promoting interoperability, and they've changed the program again in 2019. You should be using a 15 edition of certified EHR technology. So they've got 4 objectives. We'll show you the 4 objectives. Again, 2015 CERT is what they call it, certified EHR technology. And you must submit data from each of the 4 objective categories. There's no performance, a base score and performance score now. It's just your objectives. You must submit in all 4 objectives. The next slides I'll show you will be easier to see that. The 4 objectives are e-prescribing, which has been around for a while, health information exchange, public health, and clinical data exchange. So you need to submit in those 4 categories now. They don't have required and performance. So if we just look at the objectives, e-prescribing, HIE, provider-to-patient exchange, and public health, you're going to go right to the 40 points, right? I want to make sure I can do provider-to-patient exchange. And then I'm going to look at the health information exchange ones, because they're 20 points each. So I took this off of the specs. From Medicare, basically they're saying you need to provide patients electronic health access to their health information. And what is critical here with regard to APIs is that the word between the 1 and the 2 here, it's an and. So the patient is provided timely access to view their health information, and they're making available to the patient any application of their choice using an API. So the EHR needs to have an API to say that we can do this promoting interoperability measure. So any EHR saying, well, we don't do APIs, isn't doing this measure then, can't do this measure for you. So they can do them, and you'll see it's an and, it's not an or. It's a requirement that the API be available for exchanging that data to the application of a consumer's choice. And then your other big one, so that's your 40.1. And then you've got your 20.1 under here, support of an electronic referral. So basically that you can make a referral, create a summary record using certified health technology. That would be the CDA or some subset of it, or a FHIR resource if you have it. If you have FHIR in the EHR that you're using. And, another and, you electronically exchange that summary of care record. So you're making a transition of care or a referral, and you're going to send that record electronically on that you've generated from your certified health information. And then the other one is the receiving person. So the receiving person of that record that you have referred, you made a referral, you sent them that record, this is the receiving. The other 20 points is that you did a clinical information reconciliation from that data that was exchanged to you. So those are the top ones, and then plus, so you've got the 4 objectives, and then plus you have the attestations. You have to submit yes to prevention of information blocking, yes to the direct ONC direct review attestation, and submit yes to the security risk analysis measure. Yes, the prevention of information blocking is basically saying I haven't intentionally blocked the sharing of data. If my EHR is able to do it, I comply with the request. Measures are being scored a little bit differently. They're going strictly to numerator and denominator. Again, I'm not going to read every slide to you. I put more of this on here just so you'd have it for reference. But really in 2019, they're simplifying it, and they're moving towards the GPRO measure methodology, where it's basically a numerator-denominator unless you fall into an exclusion category. How should you submit data? You can submit as a virtual group. The first one here is a virtual group now. That is available to you. Small groups of physicians. We talked about this on previous webinars. Maybe you group all your primary cares by geography or by size, smaller physicians. Only go into my virtual groups. Specialists go into separate virtual groups because they might be doing different measures. And then you've got your individual groups, third-party intermediaries, etc., can submit the data. The other option is third parties only, and they basically do that through Medicare's new API, which, to be honest, is wonderful. That all that data can be processed to Medicare in the click of one button for 50-some ACOs is truly an achievement for Medicare. So who are your third parties? In an ACO, you don't have to be a qualified registry. Most of the vendors are, though, are a qualified registry or a qualified clinical data registry, but a third party could just be otherwise qualified. Again, they don't have to be a qualified registry. But Medicare doesn't, for ACO, doesn't have a separate approval process. Like for MIPS, you have to be a qualified registry or qualified clinical data registry. You have to get that approval. Our next phase we're going to talk about, so we talked about the data sets. We've got the CDA, we've got the FHIR resource, which is wonderful, and we've got the QRDA for quality now for the easy exchange of data. And we've got in promoting interoperability, the API application program interface is a requirement of the 40-point measure. So you can't get that 40 points if your EHR says, I don't have an API and can't do this. Then you can't get the 40 points. So those EHRs have it. You just need to get to the right person, go to their sandbox. Most of them have put out what they call application program interface sandboxes. So what do we do next with the data? So we've talked about this several times. This may be a little repetitive for some of you, but we've talked about many times about it's wonderful that you have all of this data, ACOs, and now you have the blue button data, which to us is great. It's better because it's weekly. It's updated weekly. It's much more timely. But we're making a lot of that. We have a problem now. We have a lot of data. We have a lot of reports. And we're calling this actionable data, but I don't know that providers are agreeing with us that it's quite to the level of actionable. So your other goal after quality, is to improve health outcomes and lower costs. And that comes from closing care gaps, disease management, reducing readmissions and ED visits, eliminating unnecessary services, and overall disease and medication management. So I've showed this slide a couple different times. But why are providers saying we haven't quite made the data actionable? Because they want to see it in their EHR. And the EHRs are going about it very slowly to bring that actionable data to the front lines of the provider team. So while the board may be talking about trending and our gaps in care and which physician isn't doing the BMI or isn't doing the cancer screenings, how are we going to get it to the provider? How are we going to let them know about this? And it can't be handing them an Excel spreadsheet. It just can't be they will not throw them in the garbage. They will shred them. But we have to get it to them through those APIs and in what we call actionable data. But we add a caveat to that: at the point of care. So what has interoperability now done for ACO performance? It has put APIs in the promoting interoperability requirement of the measure with the most points, 40 points, and said, you have to have this, or you can't get the 40 points. So let's move forward to taking all of that data that you're getting as an ACO team and your trending and your reports, maybe some care managers are pulling it up, and let's put it in front of the providers using that API. We call it our Ehr Api Connector. So what do we want to deliver to the point of care? We want them to know immediately their care gaps and their quality measures that aren't done. We want them to know when the patient's trending out of network, and risk stratification. We want them to know their health score and their benchmarks. So let's go through some of these items that now with APIs, what we can do, as we talked about earlier, is I go into the Cerner or the Allscripts EHR, I call up that patient, and that's all I have to do. A patient match is automatically done from the API to my ACO or my blue button data, and it renders it in the EHR. The providers don't have to do, the provider team, I call it the team because the physicians aren't the ones normally doing this when you come in for a visit. Someone else has brought this up for them, so that they can go in here and they can know the objectives of the ACO immediately. What's the benchmark, the risk score, the cost, utilization, where are we at with quality, care gaps with this patient? So I'm not going to linger on every slide too long, but what type of information could we start getting to them? I think the biggest piece of information, what I hear from physicians is, okay, so patient comes in, I know they're in an ACO, is their spend high or low? I have no idea. We tell them in the API will render to them patient requires attention, spend is greater than expected in their EHR when they call that patient up. And then they get key points to start looking at. What quality isn't done? What are the care gaps? But more importantly, when they see this red bar, we want them to go directly to cost and utilization. And we'll move down through this as we move forward. So first, provider team instantly knows this patient's spend is greater than expected. If I get too many patients like that, I'm never going to get shared savings. And now ACO performance is more critical than ever, right? We have to perform. We've got about 1.5 to 2 years of no risk, but then we have to be in a position where a provider that gets this message in the EHR, the spend is greater than expected, I'm going to look at the cost and utilization. Why were you admitted? What was your ED visit for? 50%, Medicare says 50% of ED visits are medication related. Most providers also do not know the patient went to the ED or the hospital because the hospitalist probably did the follow-up with them. So again, it is alerting the provider or the provider team as to what's causing that spend. Where are you at with quality metrics? So I can have my ECQMs set up in the EHR that feed to the QRDA but I got to do them. I got to get them done, right, for them to feed into the ECQM to the QRDA. So let's tell the provider right there. For the quality subset that you're doing for ACO or for HEDIS, here's what's not done for this patient. Let's get it done so that it can be extracted in the ECQM. And what are the disease care gaps? It's a diabetic. What's not done for this patient? HbA1c, LDLs, retinal exam, etc. So on top of the quality, we can also apprise them of their care gaps. And if they so choose, at that provider team, let's make sure when you're going to code the diagnoses for that patient, if you don't code these crossed out ones again, a diagnosis falls off after 12 months. If you don't code it again, it's going to fall off. So this patient's score, if we don't recode diabetes without complication, their score is going to drop, even though they still have that condition. So it prompts that provider team, make sure all the diagnoses are there, make sure they're all coded so they stay on for 12 months so that the patient's risk score is correct, because their risk score is what calculates the benchmark for every single patient, their financial benchmark. And then they can also, we really see it as one of the last tiers after everything else we went through, they can know how to network. You can easily see on this, so we color code it for them if the nurse team, provider team wants to drill down and see, well, where is this patient all going? But again, you have to make them apprised of your network. So we've been talking a lot about this API, but now we have all this data, and yes, we need to clean up the data, we need to get that initiative going, but the FHIR resources and the exchange of data is better than it's ever been before. It's just a lot of data, and we want to make it more actionable, more seamless, and we want to put it in the hands of the point of care. So again, we want all patient encounters, not just what's at the EHR. Medicare has done that with Blue Button and with the ACO data. Other payers are following suit, and EHRs with sharing of data are also following. So there's instant access to all these different payers, programs, and populations through the sharing of data. And we want to make that data, as we went through, actionable, feed it through the API, and make it actionable to the provider to take action, or the provider team. So again, we talked about the methods of data exchange, but the API is really at the top. That's really where we want to see everything going. The others are great ways to exchange data, but the API, again, can be a push-pull, and we can do a lot more with the data. Looks like I got a couple of duplicate slides in there. So your implementation options, encrypted string, which requires work on your end, or the API, which doesn't require a lot of work on the end users. So this is an example of the Allscripts sandbox. So you can see they are developing sandboxes. So if you want to go in and you want to set up a sandbox with Allscripts to start retrieving data, we can go into the sandbox and we can start using staging data, and we can get all set up, get approved by Allscripts. And then once we have a client come along, we're already set up in their sandbox or in their store, as some of them are calling their EHR store. And it's just a simple, let's activate the API with Allscripts, for example. What EHRs can do, the API, or we can work with, all certified EHRs. We remember that promoting interoperability, the API is a requirement there. It's an and. It must be available. All EHRs with API functionality that aren't certified, and EHRs with IT staff who can do the encrypted string. The API is much easier because we do all the work. This is who we have existing relationships with. So you can see the list here: Allscripts Pro, TouchWorks, Athena, Cerner, Epic. Meditech, so there's quite a few of them, and it's growing every day. The APIs are becoming more and more popular because the EHRs can't keep up with the demand of what is asked for in population health. So existing API relationships usually take a vendor about 7 to 10 business days it should take to feed their data from the other vendor into the API to render it in your EHR. New relationships anywhere from 14 to 21 days. The bulk of that time on both of these is testing. You want to make sure the patient match is working, so that's the bulk of the data. Cost, we don't charge clients extra to do the API. EHRs vary. Allscripts has a nominal fee for each call, whereas I think Athena told us the other day they were waiving their fees to get API connections going. We do have an alternative to our APIs, our patient search, as many of our clients. So you can call up all of that information, but you have to go into our system. So that's not interoperability when you have to log in separately to our system. But just know that there is an alternative until perhaps you get your API with your EHR set up. You can go in and you can search for that information when the patient comes in, pull it up, and have it available rather than holding on to an Excel spreadsheet. You can at least enter the patient's information and move forward. And the last piece I'll talk about is provider performance. All of that data accumulates into what? We can come up with spend, benchmarks, quality performance, all of these pieces by using those standardized formats, especially the QRDA for quality. I can't stress that enough, especially for our clients. We want you to see using that QRDA so it's seamless quality reporting, no manual key going forward, and you're not going to have skips because you're going to be apprised when that patient comes into your EHR, into your clinic point of care, using the connector, using that API to tell you what measures aren't done, so you'll slowly see your scores increase. I don't see any questions, but I know we're trying to keep right on time because the Medicare webinar is right after this, but if there are questions, you're free to send them to me.
Yes. Oh, did you want to go ahead and do some questions now, Chris, or?
I can. If people want to stay on, I'll just put up my contact information for those that want it. We have a question about what do we believe is the most reliable and complete method to get external EHR data into a data warehouse like Epic, Caboodle, and Healthy Planet. Is the best method still ETL? The best method is still ETL, the traditional ETL, and then moving when you do the extract, transfer, and load. I think the FHIR is better than the CDA because the FHIR resources are much more flexible choosing what you want. So the more EHRs can move towards the FHIR, the better is what we see.
Okay, there are actually a couple other questions, Chris, that came in, so I'll go ahead and put one on the screen here. This is, have you found self-insured employers have the analytics staff capable of receiving data and using it in an actionable sense?
Most of them do not have the analytics staff. But what we're trying to do with self-insured employers is engage the consumer and the provider both in the program. So if you're a self-insured employer, you control your plan. You have the TPA, so let's start making it a requirement that that this data starts rendering to an API to the provider, but also to your enrollees. So we have made it so that the self-insured teams, they really don't have to do anything. If they want the encrypted string and they do want to do the work, they can, but only the really big ones. Walmart, for example, we worked a little bit with. Only those really, really big ones have their own team. The rest are really relying on us to send a text alert to the consumer, the enrollee in their plan, and to build a methodology for their providers to access the gaps in care for a patient.
Okay, great. And we have one additional one. This one is also from John. It says, does the Health Endeavor system expedite an ACO's ability to track its overall cost and quality benchmarks in a more timely fashion?
We think yes, it does. Even with the ACO CCLF data, I'm urging ACOs to move towards Blue Button because you're getting your data, it's the FHIR resource, and you're getting your data updated on a weekly basis. All it takes is the patient to click a button and say, yes, I agree to share with you, and your analytics become much more recent and much more timely for you. Okay,
great. Oh, we've got another question that just came in. I'll read it for you. Also from Michael, it says, when building clinical data integration in an ACO, do you believe that it is feasible to import EMR data from numerous different systems and normalize the data for analysis, or is it necessary to get everyone on the same EHR?
Absolutely, it's feasible. Everyone does not need to be on the same EHR. One of our largest systems, the largest number of EHRs, has 58, I believe, EHR systems that we bring the data in and analyze it, process it. So I don't think that's a requirement. That's asking a lot of your ACO participants when they really don't need to. I think it's absolutely feasible because we're doing it, that you can get it from numerous systems.
Okay. Well, that does it for the questions for today. So we'll go ahead and conclude at this point. Thank you, Chris. Great presentation. And again, for those, if there are questions that you do have, Chris's information, her contact information is here on this slide. And so I would encourage you to write that down and feel free to make a note of that and contact her directly. And lastly, be sure to visit the Health Endeavors exhibit booth on ACOexhibithall.com to learn more about them and connect with their team and to answer any of your questions. So that's going to conclude it for today's webinar. Thank you, all of you, for attending. I hope you found today's presentation very informative and helpful. And there will be a recording available that will be sent to those attendees, but also it'll be available on the ACO Exhibit Hall website. So have a great rest of your day, everybody. Thank you for attending.
Thank you.